Okay, so we should be off and running. Let's get everybody in focus. You got seats up at the scope?
Over here. Richard's. I think. Far away.
Oh, no, we're popping.
I'm sorry, we're getting...
I thought I saw him using the horn from far away, but maybe it was just parakeratosis. And so that would be more of like a PRP with the alternating.
So parakeratosis in sort of a checkerboard pattern. You also have, do you have hyper or
That
hypogranulosis?
is hyper.
And in psoriasis, you typically have
The opposite.
the opposite, yeah, hypo. So checkerboard, parakeratosis, hyperkeratosis. Is there thinning or thickening of suprapapillary plates?
It's thick, which would go with PRP.
Yeah, which is, again, just the opposite of psoriasis, because psoriasis tends to have thinning of suprapapillary plate. Other little things that help, if you look at the vessels, there's usually vascular congestion with rouleau formation in psoriasis, and you don't see that in PRP. So PRP suprapapillary plates are thick. In psoriasis, they're thin. Vascular congestion in rouleau and psoriasis, not present in PRP. Hypergranulosis in PRP. The alternating checkerboard pattern of parakeratosis is characteristic. You can see parakeratosis adjacent to or lipping the rim of follicular orifices. And then what else do you see sometimes in PRP? Especially down in adnexal structures. Acantholysis. So you don't really think of it as an acantholytic disorder, but that's very characteristic in PRP.
It's like maybe porokeratosis.
So if there were a coronoid lamella at the edge, the center of poro can look like anything. Do you have acanthosis or atrophy of the epidermis?
Acanthosis.
And hyperkeratosis, thin corneum,
Hyperkeratosis.
hair-bearing skin or non-hair-bearing skin,
Hair-bearing skin.
and yet you have a stratum lucidum like you would have on acral skin.
Yeah, LSC.
Yeah, exactly. And you have angiofibroplasia of papillodermis. So you can see either vertical streaking of collagen in the papillodermis or just sort of fibrosing granulation tissue, which is they call angiofibroplasia. So there's a lot of vessel, a lot of fibro going on in the papillodermis. And those are LSC prurigo type features. What's the difference? If it's a bump, it's prurigo. If it's a plaque, it's LSC. That's about it.
So that was not coronoid lamella.
That was not a well-formed coronoid lamella, but you are never wrong to think of syphilis, and you are never wrong to think of porokeratosis.
Okay, so there's acanthosis, pretty regular. Some hyperkeratosis, looks like there's something in there. Probably parakeratosis. Possibly. I'm trying to see if I see any newts in the corneum.
And I do not. I just see para.
Yeah. Let's see. The suprapapillary plates are kind of thick.
You are
Almost
correct.
looks like PRP again.
Yeah, so again, you definitely have an alternating checkerboard pattern, more accentuated around the follicles. There's follicular plugging. This is definitely rubbed or scratched PRP.
Yeah.
PRP is often pruritic, and you definitely have some superimposed LSC type changes here. And that's exactly what it was kind of Prudic scratched PRP. Now remember, we can jump into any chapter, right? Because at your stage of training, you know all.
So at the DEJ, it looks like there's an infiltrate. It almost looks sawtoothy.
So, I'll accept that some of them are a little skinny. In general, though, are they rounded or are they pointed? I agree with you that they're more rounded. And given the fact, and you phrased that in the form of a question, so for Jeopardy, you were great. So, if they're rounded and you said inflammation at the DE junction, what kind of category are you going to put it in?
Well, if they're rounded, inflammation, more vacuolar than
Yeah, so a vacuolar interface, and then what do you want to know about vacuolar interface?
If there's a lymph in every hole.
And so is this lots of holes out of proportion to lymphs, or is this closer to lymph in every hole? Let me get that.
I think it's almost lymph in every hole.
Lymph in every hole, and then what's all that red stuff out in the corneum or in the epidermis?
Are those extravasated RBC?
They are. And so interface dermatitis, lymph in every hole, red cell extravasation.
There's pleva and PLC.
So pleva and PLC. And do you see a real dirty scale crust?
Yeah.
I'd say not so much. Pleva usually has a thick, dirty-looking neutrophilic scale crust and a dense, superficial, and deep infiltrate. This is pretty much superficial, no big, thick, dirty scale crust. So, PLC. Okay. And in sign-out, we just tend to say pityriasis lichenoides and not worry about acute or chronic because there's actually a lot of overlap.
Kind of looks. I can't tell if there's a newts in the horn there, like a little scale crust maybe. Looks like you kind of have like acute on chronic horn there, like subacute maybe, and then maybe a collection of newts in there.
So, definitely have a horn that is a subacute horn. How would you characterize the process?
I'd say vacuolar again.
I'd go more spongy, honestly,
Okay.
for this one. And that pattern of the horn just seems to continue everywhere, right?
Kind of has a tinea pattern.
Okay, it's a very much a tinea pattern. And tinea, remember, can look like anything. It's commonly spongiotic. Occasionally can be interface. What you thought was a collection of newts is actually a collection of hyphae. They're and nuclei and some parakeratosis in there. But the place you'd look for hyphae would be in that layered horn. You wanna, that's the area where you're gonna look. So basket weave on top of compact. You always look for tinea. That's a big clue for tinea.
Looks like you have some scale crust there. Looks like maybe some neutrophil.
Our slide is a little smudged, but let's look up above. And tell me about the corneum.
And it looks like the same kind of subacute that we had before.
Yeah, definitely orthokeratotic there. How about here?
More compact, yeah.
Yeah, more compact with nuclei, so parakeratotic. And then you go along and you hit orthokeratotic. And then you go along and you hit compact and parakeratotic,
It's like Ilvin.
like an Ilvin. That's exactly what it is. So, Ilvin is commonly psoriasiform. And then the clue is, as you go along from right to left or left to right, you hit areas alternating ortho-para, ortho-para, ortho-para. But it's a left to right, east to west type of alternating pattern.
Just have shade. It's like orthokeratosis top. It's hard to
Yeah,
tell.
and it actually shows up a little better up on the screen, I think, than on the scope.
Power of the upper, like of the stratum spinosum. I think like nutritional deficiency.
So pallor and edema of the upper third of the stratum spinosum, like nutritional deficiency. So what things fit into nutritional deficiency disorders?
Pellagra, acrodermatitis enteropathica, glucogonoma, necrolytic acral erythema.
You got your list pretty well. So necrolytic acral erythema, which is a manifestation of,
Hepatitis C.
and acrodermatitis enteropathica, which is,
Zinc deficiency.
and pellagra, which is
Vitamin B12. Niacin.
Niacin. niacin's B2.
D2.
And then what else did we miss? Oh, glucogonoma, which
B3,
is
right? And B2's right.
Riboflavin.
you are correct. You are correct. B3, B2 is riboflavin. Thank you. In the south, so we're kind of ground central or ground zero for pellagra in the Old South. Southern sharecroppers lived on meat, meal, and molasses. The meat being fatback, the meal being cornmeal, and molasses from the rum production. And and that's a very niacin poor diet. There's plenty of niacin in corn, but it's not bioavailable. So now by law in the United States, any corn product sold as a dietary staple has to be processed with alkali. So if you look at your typical Doritos, they just say cornmeal. If you look at corn masa that's going to be made into tamales and things, or you look at corn tortillas, it says cornmeal processed with alkali. That's so that people don't get pellagra anymore.
Parakeratosis.
So parakeratosis. Do you see much spongiosis?
A little.
Yeah, I mean barely any. How about your suprapapillary plates? Thick or thin?
Thick.
Thick. So thick. And is there a little parakeratosis or a lot of parakeratosis?
A lot of parakeratosis.
And an accompanying lot of spongiosis? Not really, right?
Yeah.
So you have parakeratosis out of proportion to spongiosis, thick suprapapillary plates. What might you think of?
PRP again.
Yeah. So PRP, sometimes you don't see checkerboard. You just see lots of para. And one of the clues is that the parakeratosis is out of proportion to the spongiosis. So it really looks papulosquamous rather than dermatitic, rather than spongiatic.
Dr. Johnson, it seems a little bit like dimmer than it was earlier. Is the polarizer on or something?
I am not sure what happened here. Let's see if we got something.
There.
There we go.
Yeah.
Yes, the polarizer got bumped in. Thank you.
So we got some hyperkeratosis. I don't really see any para. Looks like it might be some like angiohyperplasia.
There's
Below,
definitely
so maybe like
hyperkeratosis and lots of angiofibroplasia. And this is a nice example where it's not really vertical streaking, but there's a lot of angiofibroplasia there, and that's a LSC pattern. Good.
There's some hyperkeratosis in the edge. There's some para. The suprapapillary plates look a little bit thinner in this one, but I don't see a bunch of newts in the horn. Looks crusty. Yeah, it's my favorite.
Oh my
Hate those.
Not very well formed.
Say it.
No, Oro.
Poro, of course it's Poro.
Of course.
So I wouldn't say not very well formed.
The other one was
Meet you.
It's there on either side, and so remember, Centroporo can look like anything, and so keep high index of suspicion for it.
It's a Caitlin pile.
Maybe PPD.
So if there is significant erythrocyte extravasation here, you might think of a spongiotic PPD. What kind of PPD is spongiotic?
The Greek one.
Yeah, the Ducas and Kaplanakis. So the Greek names go with the sponge divers or spongiotic. You think this is chronic or
There is some hyperkeratosis.
there's some papillodermal fibrosis, right? So it looks like a subacute sponge, but there's definitely some chronicity here in the papillodermis, right? Any other clues?
Horn.
Tell me about the horn.
This looks like a tinea.
Looks like a tinea horn. Basket weave on top of compact. So that is, in fact, another tinea, which is a very common cause of spongiotic dermatitis. Okay.
Parakeratosis. It's like there's a little pigment there. A little pigment in the papillary dermis.
Okay, there's a little pigment in the papillodermis.
This Candida. Is that Candida?
So you said there's parakeratosis. Is there hyper or hypogranulosis?
Hyper, so I guess it should be lost. So this is the granular.
And the granules continue all through that parakeratotic layer, so you are correct that it's granular parakeratosis. Very good.
How do you treat that, Dr. Austin?
Sometimes topical retinoid together with a corticosteroid for the irritant effect, and also find out what they're using. Because often change of their personal products will often lead to resolution. It's not quite clear what's causing it. We identify it with increasing frequency, but the cause is still somewhat a mystery.
So there's lots of newts. So I feel like it's probably like the PTIX differential.
Okay, so what's in the PTIX differential?
Psoriasis, tinea, vitiligo. Staph syphilis,
Candida subderm
subderm.
The I was the impetigo, which was
Thanks.
the staph part. So psoriasis, tinea, impetigo, candida, subderm, syphilis, PTIX. And this person is covered, studded with tiny little pustules, started on their face, spread down their body after they started a beta-lactam antibiotic, and they have no prior history of psoriasis.
Hijab person.
Exactly. But it's actually, I lied, it's actually restricted to their face, and it happens every time they get a URI. That's ALEP. Acute localized tends to be just head and neck, and whereas a JEP is almost always an antibiotic, a LEP usually is recurrent and follows URIs, almost like sweets would follow a URI. But it's pustular and localized.
There's pericarditis. There are a bunch of granules also in the horn.
So perikeratosis with a bunch of granules also in the horn.
I think it sounds like granular.
It does sound like granular perikeratosis. Very good.
Looks like, I can't tell, is this like mucosal surface?
So it yeah, possibly, probably not, because it really looks like there's a bundled dermis. Mucosa doesn't tend to have bundled dermal collagen, but
I can't tell what those like nests are down at the DEJ.
so you may have nests or you may have pseudonests of inflammatory cells and dead keratinocytes. Tell me about your
Little bit.
reedy.
They look kind of sawtoothed.
What kind of sawtooth?
So potentially like LP, I mean lichenoid differential, yeah.
Yeah, so lichenoid. So tell me about the lichenoid differential.
Oh, you can have LP.
You brought it up.
LP, melanoma, lichenoid drug, BLK,
Lichenoid GVH.
GVHD, yeah.
And how about this one? Anything bad for LP?
I'm looking for para and EOs.
Yeah, so you'd look for EOs. I don't see any EOs. Para, there's maybe a tiny little bit of para there, which, not a whole lot, but
Yeah, there's a
enough
little
at
bit
least to
there,
make you start looking for lichenoid drug and things that are not real LP. To at least get you thinking in that differential.
It's like you have a basket leaf stratoconium, tumors. I've seen neutrophils. You have spongiosis.
And is the corneum all basket weave?
Well, it looks like there's a little contact beneath. So again, I guess the tinea.
And this is tinea again. Okay. So you get a stain.
We have some fungus in the sternum corneum,
And what direction?
vertically oriented.
So more likely,
Tinea, which is Candida.
more likely,
Oh,
tinea swims, Candida
Candida.
dives. Okay.
Canada's on top of the U.S.
Oh, wait, what was that?
No, like Canada's on top of the U.S., so it's vertical.
Ah. But Canada's kind of horizontal on top.
Well,
I know.
yeah.
I like
Okay.
it like
What the-
this.
Did that.
I've got some pictures too. Like sketching my throat with documents.
But will they be part of NAFTA?
That's a good question.
Lot of plasma cells.
Lots of plasma cells. So syphilis.
Should be considered. And diamond like keratinocyte.
Diamond-shaped keratinocytes with a little spongiosis in between them. So this is probably
Zoom balanitis.
Zuhn's balanitis, or according to Dr. Mays, it's zone, right?
Oh, yeah.
Rocked my world.
I think phonetically.
The O is silent.
Still work.
There's a logo.
Look rusty. And there's lichenoid. Shoot up.
And what kind of cells are in here?
A lot of histiocytes, maybe.
Lots of histiocytes. Do you normally get histiocytes in something that's LP?
No.
So when you see something interface with, first off, with what looks like lymphs with too much cytoplasm, what do you have to think of?
Like the histiocytic disorders like LCH and mastocytosis.
Usually those aren't interface.
Okay.
So interface, lymphs with too much cytoplasm, you have to think of syphilis, correct? You always have to think of syphilis, right? And then the other thing that's kind of LP-like but restricted to individual papillae with a histiocytic component would be little ball and claw, like Lichnididus, which is the other, and that was called Lichnididus, and not Miss Fire keeps saying.
I think I'll take this one. Again, some hyperkeratosis. There's some newts in the horn there, I feel like.
So some newts in the horn.
So, but I don't feel like it's very psoriasiform.
So when you say it's
looking at LSA, or LSC rather.
LSC, exactly. So this is crusted LSC. So not everything with newts in the horn is psoriasis. You know, this is probably just a little impetiginized prurigo. But it has the very irregular acanthosis. Why is the acanthosis so irregular in LSC and prurigo? Because the only thing that becomes acanthotic is the adnexal epithelium. So all of these little skinny things up here are the pre-existing epidermis, and everything that's massive, you can see the ducts in it, or the hypergranulosis of the center of a hair follicle. So it's the adnexal structures that become acanthotic in LSC, and the intervening dermis is the thin, skinny stuff. Okay. Walk through that chapter. Now we're going to do half an hour of potpourri. Fasten seatbelt.
There wasn't even one psoriasis in there.
I'm sorry?
We didn't even get one psoriasis.
No, because you know what psoriasis looks like, right?
No softball spikes.
There's a punch, but I'm not really sure what's
Okay, what's that?
smooth muscle from my hair.
Yeah. So erector pili, where's the hair?
It's missing.
Where's the sebaceous gland?
It's missing as well.
So this is probably,
Could be early morphea, like a scarring alopecia.
so early morphea or a scarring alopecia. Does it look like there's any loss of space between these collagen bundles?
Just on the very superficial part, but not elsewhere.
And how about here? Does that look like a normal fibrous tract?
No,
Yeah. So more likely
scarring alopecia.
Yeah, and so pick a stain.
Elastin stain,
Good choice.
not require horses.
Yeah, so I mean that would be a good way to look, and even without it, it looks like this is a little bit thickened here, but is it thickened in the lower portion? Not really. And see how it kind of is wedge shaped at the top here.
Right.
So give me two things that in the burnt out phase can look like this.
Follicular to Calvin's.
Follicular to Calvin's and
LPP.
LPP.
Is there a reason that there wasn't like a cross-sectional? Or was there lucid?
Because a lot of them, it depends on the lab how they're going to be processed. So in our lab, all your context clues, in our lab, we use the Tyler method, so you always get vertical and transverse, but that was somebody else's lab.
Big nodule. Let's see. Fascicles.
Of cells that are
Fusiform.
fusiform, some might say spindled, and they're absolutely straight,
No, kind of wavy.
making you think of
Um,
loose, uniform, kind of gray, mixoid. There are round mast cells all through it, and then the wavy spindle cells, jumping dolphins,
neurofibroma.
neurofibroma, you are correct.
So there's a punch, there's lots of cardiovascular inflammation, some acanthosis, epidermis. Horn is somewhat compact.
Horn is somewhat compact. How about up there?
Basket weave over here.
So basket weave there. How about there?
It's compact there.
So you're telling me it's basket weave over compact?
Yes. So that's maybe tinea.
That's what it is. Look at it up on the screen. It's probably better there.
It looks like glassy epithelium.
Glassy epithelium.
Can't really see up there, so look in the scope.
Okay.
Sorry. Glassy epithelium.
Do you have a basal layer?
Not quite.
Not really.
Yeah, so maybe invasive spleen.
Kind of sawtooth. All right, sawtooth with a band-like infiltrate, but it's glassy and has lots of PEH of the adnexal epithelium. So it's like a hypertrophic lichenoid dermatitis. So what things give you hypertrophic lichenoid dermatitis?
Like hypertrophic lupus.
Hypertrophic lupus and
You can get LP too.
yeah, hypertrophic LP. And what's going to tell them apart most reliably?
Well, you can get more follicular plugging and DIF. You can get that.
Any
lupus.
study you can get?
I'm sorry.
Any study you can get?
DIF.
Yeah, exactly. That's one where DIF is just golden. So not all lupus is positive on DIF, but all hypertrophic lichenoid lupus is. You know, it's a strong granular band, lots of IgM around the follicles.
Potentially like a blue Nevis.
Potentially like a
Decent
blue
diffraction.
Nevis. Right? So, do you see sclerotic collagen in that blue Nevis?
Maybe a little bit.
Maybe a little bit. So, that's the question. If there's lots of sclerotic collagen, it's a blue Nevis. If there's no sclerotic collagen, then you got to worry about metastatic blue melanoma. And so, or blue Nevis like melanoma, uveal type melanoma. So you can look for MIB, you can look for BAP deficiency, you can look to see if the collagen blacks out, which it does sort of in this case. So blue Nevis, you are correct.
So there's your cross section.
There's your cross section. What's that?
Looks like miniaturized follicles.
And what's in the center?
With the pigmented profile.
Yeah, what's the brown stuff in the center?
Like, I don't know.
Pigment casts.
Okay.
So pigment casts being spit out. Lots of pigment casts. Right, so what things have pigment casts?
Trichotillomania.
So trichotillomania, what else? So trichotill's one, and then two others. Alopecia areata and not androgenic, alopecia areata. So trichotil, alopecia areata, and every time you say AA, you have to say syphilis. So trichotillomania, AA, and syphilis, those are the three. They all have catagen hairs. They all have hair casts. In this case, see the weird shapes of the inner root sheaths here? How they're kind of collapsed in weird, bizarre shapes. That's really good for trichotil.
Orthokeratosis. A bit papillomatous, and then there's
Normal amount of
fungus and
keratin,
a little bit hyperkeratotic.
a little bit hyperkeratotic.
There's blue structures there. Oh, I see a yeast form. Oh, there's some of the hyphae forms. They look more horizontal. Bless you.
So, well, are they clear or are they taking up stain?
They're taking up stain.
Okay, tinea and candida don't take up stain.
Okay.
So which one takes up lots of stain? So it looks gray, TV.
Oh, okay.
So here you got the ziti and meatballs, and the easiest way to tell at H&E is, first off, tinea tends to be in a layered horn just above the granular layer. Candida tends to be vertically oriented. TV is in an orthokeratotic scale. Remember, the Furfuraceous scale is your only orthokeratotic scale. All other scale is parakeratotic. And it's gray because it takes up a lot of stain, whereas tinea and candida don't. Okay.
Structure. Slightly cortical. Connected with spacious gland. Steatocystoma.
Steatocystoma, well done.
That was easy.
Cartilage here.
Cartilage, happy cartilage?
Not so happy.
Not so happy cartilage. Why is it unhappy? Or in what way is it unhappy?
It's not really inflamed, but like kind of degenerated a little
Not really inflamed, but degenerated at the sides
Yeah,
or right in the middle.
in the middle.
In the middle. So what do you call it when your cartilage degenerates in the middle and kind of splits apart?
Borderline pseudocyst.
Pseudocyst. That's it. So pseudocyst of the auricle. Let's see what we got here. That's good.
Alright. So, little nodules of schmutz in the middle. I'm not sure if that's some sweat or something else.
So what is it? You see it better up on the screen.
Oh, okay. Is that, yeah, is those crystals?
Yeah.
So, perchance gouge or some other crystal?
Yeah. Which one is feathery like this?
Gout.
Gout. That's gout.
What sort of histiocytic in the center? Some of the, like the ends look like infiltrated BCC.
Yeah. And if the ends are infiltrated BCC, what's the middle?
Infiltrated BCC.
Yeah, it is.
Okay.
But it's just where you get that fibroblastic stroma and the little strands of cells, kind of hard to tell what's epithelial and what's not. Often the edges, it defines itself better.
Cystic structure there.
Cystic structure with an epithelial lining?
No.
Not really, right? It's kind of fibrous with those plump fibrocytes lining it. So what kind of cyst is this?
Fibrocyst.
That's actually not bad. That's what a ganglion or metaplastic synovial cyst looks like. Okay, where are we?
The hair bearing area, probably maybe the scalp.
Scalp.
Um,
How old's the patient?
I think young. Old.
Okay. So, you had a 50-50 chance. Okay, so is the collagen normal sized and pink or small bundles that are fairly red?
Small bundles.
That are fairly red, yeah. So it's kid skin. Okay, and so you got scalp, and then what's wrong with the scalp?
So it's missing some hair.
Missing hair.
So maybe like a nevus sebaceous, possibly.
Do you see anything that looks like nevus sebaceous there?
Well, like a prepubertal was what I was thinking.
Do you see little vertical hair germs lined up?
No,
Or does it look more like scar?
it looks more like scar.
What would you call a hairless patch with scar in a kid?
Like aplasia cutis.
Like aplasia cutis, and then what's underlying this aplasia cutis? vascular-like spaces, tons of tiny little collagen balls, all of them wrapped by those blue cells. So what in a kid looks like aplasia cutis and has something underneath that looks like a vascular lesion with tons of tiny little collagen balls all wrapped by little blue cells. Anybody? Meningocele. So that's meningocele, or rudimentary meningocele on the scalp. Presents like aplasia cutis, vascular-like spaces in the dermis, everyone full of little collagen balls, all wrapped by the meningocelial cells.
Biopsy is not the preferred initial diagnostic test, right, for that?
Often they do end up getting biopsied. I mean,
That's
that's,
the idea.
we certainly see lots of biopsies of them.
So we have a punch biopsy,
Punch biopsy.
some scattered infiltrate. There is a hair follicle that's preserved.
There's a hair follicle that's preserved. There are other rectopili that are orphaned. Tell me about the amount of space between your collagens.
It looks pretty decreased, or
Pretty decreased, making you think of.
it could be scarring.
Do you see an increased number of nuclei like a scar?
No, could be morphia.
Anything you might want to do for confirmation?
We could get a CD34.
CD34 would be a very, very good thing to
Does that
do.
patient also have tinea? The horn was acute on chronic.
Take a look.
Maybe not.
I don't think so, but
Thought I saw some up there.
most patients do. So, okay.
Looks like you got a lot of spongiosis with the collection of, I think it's a mixed infiltrate, but maybe neutrophils in there.
Lots of neutrophils in there.
So infectious versus.
Yeah, and you look to see, is that bacterial colonies, but it's not really. It's just kind of smudge there. So
Yeah,
this
that's
is someone
psoriasis.
with an edematous face and lots of pustules.
Maybe AJEP.
Maybe AJEP, except that he's not on any new antibiotic, and this happens like 4 times a year, every time he gets a cold.
ALEP.
Halep.
Is that like strep related or is it more viral?
Viral usually, post-viral.
So they still have that high up, and then there's some cartilage there. Don't really see
So is this a very, very thin worm-like patient with a cartilaginous core, or is it a bump?
probably a bump,
Probably a bump, cartilaginous core,
Like a-
tiny, tiny little hair follicles.
little accessory trait.
Accessory tragus, very good.
It's like vascular distal corneum. But it almost looks pretty normal. Yeah, it's like histiocytes.
Definitely have histiocytes.
If you again, like interstitial GA.
Like an interstitial GA, which is exactly what it is. Well done. No, it's not an easy one. You can pass the button over.
She's got one in front of her.
She has one parked in front of her.
That was easy.
You can do it two-handed now.
It looks like acral skin,
Acral skin.
scare, paracariosis.
And what if it's not acral skin? You have lots of fibrosis, lots of vessel, lots of thickening.
Prurigo.
Yeah, it may just be prurigo or lichen simplex, where it looks almost like liquid skin, but it's not. So subepidermal split.
Like some epidermal necrosis as well.
Epidermal necrosis. Tell me about your blood vessels.
They're all clotted.
They're all clotted.
Maybe some kind of thromboembolic.
So some kind of thrombotic disorder with clot. There's also fibrin there. There are mixed inflammatory cells with a fair number of EOs in there.
Some kind of bullshot eruption EM that as well.
Do those usually get lots of clot?
No.
So thrombotic disorder with bulla is a really, really good thought. But with all the inflammatory cells there, it could just be because it's an old bulla, but the inflammatory cells go pretty deep in perivascular as well with EOs. So what kind of subepidermal bulla has lots and lots of clot associated? Anyone? Tick bites. The thrombi are really characteristic of a tick bite reaction.
Basal shell, or
Yeah.
it's kind of mucinous.
Yeah, adenoid. Adenoid BCC. Cystadenoma, does it look like a complex wall?
Not really. So maybe it's just a simple
Yeah.
eyelid cyst that
Gets called a hydrocystoma.
I was going to say HPAP, but it's not HPAP.
Maybe on head and neck skin with spacious glands.
And what's that?
Looks like a basal cell. Or
Like a little
Basal
basal
gland.
cell associated with sebaceous glands and a little papillary mesenchymal body, and then there's another one and another one and another one, and they're all lined up on this hairless patch on the scalp of the kid.
Oh, nevus sebaceous.
Prepubertal nevus sebaceous.
There's hyperkeratosis. Acantholysis in there.
Just acantholysis.
No, there's some dyskeratosis too.
And are the cells normal or abnormal?
They're abnormal.
Yeah, kind of large, atypical cells, budding downward, acantholytic.
Like a squame.
Yeah, or one step short of a squame. Just acantholytic AK.
There's, I can't tell if it's on acral skin. It's pretty hyperkeratotic. Some regular acanthosis, patchy infiltrate. Could be
So, could be tinea. There's papillodermal fibrosis, which you can get in tinea. There's an infiltrate around the vessel. nice and symmetrically all the way around the vessel, just as much under that vessel as there is above that vessel? No, not so much.
No, it looks like a bare underbelly.
Like a bare underbelly and papillodermal fibrosis.
Yeah.
And what are these lymphs doing, kind of lining up at the DE junction?
That looks like MF.
It's like maybe early MF. Okay, I think we're done. Well done. Welcome back. No one floated away.
You guys, reminder for SEC, did y'all get the email about the uploading